Welcome to Health IQ. I'm Dr. Alan Siegel, your host. Today we have a special guest, Dr. Stacy Spivack Gross. She's with CareMount Medical Group. She's board certified in both physiatry and sports medicine. Welcome, Dr. Stacy. How are you doing?
I'm doing well. Thank you for having me.
Good, good. So sports medicine, everyone knows. Tell us about physiatry. I think it's one of the unknown specialties that people truly don't understand in medicine. Tell our people what it's all about.
Sure. So physiatry is definitely not a very well-known field. It really became popular in the 1940s after World War II with Howard Rusk. He was one of the leading physiatrists at the time, and basically what he was doing was trying to take the veterans who were coming back from the war and basically with whatever handicaps they had, make them as functional as possible. And that's sort of what the basis of physiatry is. From there, it's expanded to where there's pulmonary rehab, cardiac rehab, pediatric rehab, pain management is an offshoot of it, and then sports medicine and sort of the office-based orthopedics, which is what I do.
Right, so within physiatry, there's actually multiple subspecialties, so you can even go even more specific into different areas. So, but Correct. It has a very historical background, which is interesting. So, right. So you're really helping people in a rehabilitative mode, possibly pain management, musculoskeletal, not orthopedic in the sense of surgical, but you're right. really trying to treat patients in a non-surgical
Right, we're trying to prevent them from having to go to the orthopedist to have surgery. So we're trying to do everything more conservatively through medications, injections, changing, either putting them into a physical therapy program or just changing what they're doing at home. A lot of people have pain at work and they don't even realize it's because the way that they're sitting is not proper. They're sitting with a desk that's too high, they're sitting with a chair that's too low, bad back support, they need to, or now the big trend is getting the desks that transition from seated to standing. So we help assist with that. So there really are just so many different things that we can do.
Right. Well, I'm glad you mentioned that because I feel, with my background as a chiropractor, sitting all day long, I don't think we were ever designed to sit all day long, and I think right. that's become a real crux of a lot of people's mechanical low back pain and what happens over time. So. Presumably, as a physiatrist, you see a lot of different common musculoskeletal complaints. What are some of the more common things you do see in your practice?
So obviously neck and back pain. I mean, those two are the main things that come into our office. But then shoulders, either from athletes or from just older patients who are becoming more arthritic. Knees, hips. A lot of people will have pain in their leg either from a true sciatic pain or from their lower back. And then we see some patients, or some of the things that I also do that are a little bit off the orthopedic track. I do kind of like the neurology component of physiatry. So I also see some gait evals and people who have MS that are having difficulty walking from a dropped foot or weakness. So we also incorporate a little of that in too.
Oh, so you like the neurological component. Besides MS, are there other things such as Lyme disease or other types of chronic issues that may affect the nervous system that can affect, gait and neurological problems?
Sure. So when people come in with multiple joint issues, obviously with where we live, the first thing you think about is Lyme disease. But I also do have to think about other things like rheumatoid arthritis or especially in a young man, do they have ankylosing spondylitis? So we also do some rheumatological studies to see if there's something else that's causing it and not just focus in on the one joint that's bothering them. We try and see what else could be as a systemic issue that might be really the underlying problem and not just the specific problem that they're coming in with.
Right, especially if it's not isolated, if they have multiple complaints and
Correct.
There's multiple joint areas that are bothering them or other
right.
symptoms that are coming up on their review of systems, things like that.
Absolutely.
I want to go back to the posture thing for a second, because I think that's really important, especially in today's day and age with like cell phones and laptops right. and computers and I'm concerned about the kids.
Right.
I'm concerned about the kids. You go into a restaurant these days, you go into any home or any social situation, and you see the kids and their shoulders are hunched and their heads are forward and they're seemingly like that for hours on
Absolutely.
end. And I feel like that could be a chronic issue in the future. Tell me if you already see some.
Yeah, it's actually interesting. Yeah. Today, actually, I think I saw 3 people who were in their mid-20s that all came in because they themselves were concerned that their posture was just getting worse and worse over the past few years. And they have exactly what you're describing. Their head is forwards, their shoulders are rounded. And what happens is they become so accustomed to sitting that way that their muscles get so tight that they almost can't straighten up and go into proper alignment. So it's very important to start getting a lot of these kids into a stretching program and an exercise program and strengthening program that a lot of them don't do.
Right, and I think that that's important. I think the strengthening and the rehabilitation component and the postural awareness, because your body will learn and relearn poor habits as much as it can relearn and pick up on good habits. So the more you do things in the improper biomechanical sense, you know, it's harder to reverse. It's so I think that's an interesting component. And then, you know, they may have headaches, they may have numbness, they may have other things if it gets really, you know, thoracic outlet type syndromes.
Absolutely, and we're actually seeing a lot more of the thoracic outlet syndrome. And it's a lot harder to treat, and it takes a lot longer, and especially in this day and age where people really want things fixed quickly, it's a lot harder to do.
Yeah, and thoracic outlet syndrome might be just explain it to our audience a little bit.
So there are generally two things that cause thoracic outlet syndrome. It can be a vascular component or more of a neurological component. And when it's vascular, that's really kind of beyond what we do, because then we have to send them to a vascular surgeon. But when it's more neurogenic, a lot of it can come from where the muscles in the neck or in the upper part of the arm here can become so tight that it actually compresses the nerves and it causes numbness and tingling, pain, weakness into the arm.
Right. And sometimes differentially trying to figure out, is it coming from the neck? Is it coming from a peripheral part of the body?
Right.
That's the challenges in, you know, ordering the proper diagnostics for that, right?
Exactly. So a lot of times we'll start just from the physical exam. We can kind of gauge where we think it's coming from, and we'll often start with a physical therapy program. And if they're following the recovery the way that we would expect them to, then we just continue it that way. And if not, if there are little hiccups along the way or they're just not progressing the way that we would expect them to, we'll send patients for MRIs of their cervical spine, nerve conduction studies, or even a vascular ultrasound to check to make sure that it's not a vascular component. Absolutely.
Right, and sometimes just, you know, being able to order the right studies, you know, as a physician, you know, whether it's MRI or X-rays or even lab tests to find out exactly what's going on. So, so with the youth population and the athletic population, a lot of these kids, you know, single sport kids, single sport athletes, overuse syndromes. You know, what are you seeing in your practice now, and how concerned are you about, you know, those things? I don't think children are doing what maybe you and I did as kids out in the woods. You know, it's like it's a little bit different these days. So.
Yeah, kids are really focusing early on one sport, and we're definitely seeing a lot of it's mostly, I would say, soccer that we're seeing a lot of, where we're seeing a lot of leg pain, knee injuries, hip injuries, even back injuries. Actually, not just soccer, also in softball and baseball, we're seeing a lot of shoulder and elbow issues with the pitchers. And the problem we find is not even so much in the diagnosing or treating from a physician standpoint, but the
culture.
The athlete themselves, they don't want to miss time playing the sport. So there's a lot of difficulty in telling them, look, you've got to stop for 3 months or you've got to stop for 6 weeks, because they don't want to stop. There's a tournament. There's something that is coming up that they don't want to miss.
And it's not only the athletes, sometimes it is the parents, it's the family.
Absolutely.
So it's a difficult situation, and knowing at a younger age that the damage could be worse or more chronic if they don't rest it. And,
and I do try and tell them that, because, you know, we all are subject to that. We all, regardless of what stage in life you're in, you kind of forget about what's going to happen in the future. And a lot of the younger kids don't realize that the damage that they're doing now is really going to be a problem for them later on. And we try to teach them ways to correct it now so that they don't have a problem 20 or 30 years from now.
And sometimes it's just as simple as, modifying routines,
Right.
spacing out some of the workouts,
Practices, yeah.
spacing out the practices. It's not always a shutdown situation. Sometimes it's just like, let's tailor it back a little bit and see how we do.
And even just, like you said, modifying what they're doing, but there are certain things that a patient will know when I do X, Y, or Z, it provokes my symptoms, and just having them not do those few things for a short time can often just be the remedy.
Right. Okay. So I think it's a matter of part doctor, part family intervention, and trying to get through those. I think there should be an alarm for the parents and understanding that, look, you're probably possibly putting the child in more risk, and they are the adult, and the child is still the minor, and
Right.
they have to help make the healthcare decisions as part of a team.
And I think the more difficult athletes to treat are the ones who are either in college or away at boarding school, because a lot of times the parents aren't aware of what's going on, and when they finally become aware, they're actually shocked with what's been going on and for how long it's been going on, because when they're away at school, the trainers or the coaches think that they can handle it, and a lot of times they can't.
They can't.
And they don't send them for x-rays or MRIs, and the condition gets worse and worse.
It's worse, right. So tell me about cortisone injections. We know they work. How prevalent are they used in a practice such as yours? What are the upsides? What are the downsides? And then, and how would a patient, decide if that's, really, what conditions do they work usually
Sure.
better for? Because I know people always ask about cortisone injections. Should I get a shot? Especially, we see a lotot of, sports medicine type patients, and
Right.
they always ask, is this going to help? Should I do it? Not do it? So I'd like to hear from your perspective.
Sure. So I think it's important for all patients to understand that the cortisone injection is not the solution, because there is still the underlying problem, and whatever caused it is still there. So whether it's arthritis, whether it's bad body mechanics, whether it's an injury, they have to understand that the cortisone injection may make them feel better, but it's not the solution. So normally what I'll tell a patient is, I'm not going to do a cortisone injection right away. Let's start in a conservative way, and if you're not getting better, then we'll do the cortisone injection. The only time that I stray from that generally is when a patient is in too much pain that they can't start a more conservative treatment. So if someone comes in with acute rotator cuff tendonitis, and they physically just can't move the shoulder, and there's no way that I can get them into physical therapy, then oftentimes I'll do an injection, but tell them the injection is not in lieu of the therapy, it's to allow you to do the physical therapy.
Right,
just to calm everything down.
Pain threshold down a little bit, yeah.
Exactly, so that then they start the physical therapy. We usually do the injections for shoulders, for knees, often like a tennis elbow or a golfer's elbow, and then if I'm seeing a neck or a back pain patient, those injections are a little bit different. Those have to be seen by a pain management specialist. So I don't do the epidural injections, which a lot of patients do confuse with just a general cortisone injection, because that's done in a more of a surgical setting.
And sometimes, historically, some patients have been told or have had a steroid injection, SI joint, maybe lumbar spine, maybe cervical spine without fluoroscopy or ultrasound guidance. And, I don't know if that's commonplace anymore these days. I know it's not usually typical anymore, right?
Right. So when it's spine related, nobody does it without fluoroscopy. That's definitely standard of care at this point.
Yes.
SI injections, some people do without fluoroscopy or ultrasound guidance. To be honest, I don't think those should be done without it either, because the joint is a very difficult joint to get into. It's at an angle. It's not a straight joint. So those should also be guided. More of the peripheral joints, like the shoulders, the knees, or like an elbow or a finger, you don't really need ultrasound guidance for those. There are enough bony landmarks that you really know when you're getting into the joint.
Space,
right, and it's not necessary to do ultrasound, and I think it just is an added cost to the healthcare system that's not really necessary.
All right, and the patient, they should be comfortable in those joints, that, everything should be fine.
Right, most physicians don't do the ultrasound guided, knee, hip, knee, shoulder, hand.
Right.
Hips, you need to have done under fluoroscopy.
Now, in terms of trigger points, some people know what it is, some people don't. Some people know they have them but don't know what they are.
Right.
It's just in general terms, what kind of is a trigger point, and how are they resolved?
So trigger points have a very specific definition, but as doctors, we don't always treat the true trigger point. So a true trigger point when you palpate it, is supposed to create a spasming type of reaction and referred pain. There are also tender points, which are often confused as trigger points. So tender points are just when you have an area that's very tender to touch. There may be a spasm underneath it, but it's not a true trigger point. When you do a trigger point injection, and there are, again, a lot of different ways to do that, there are basically 3 ways to do a trigger point injection. You could do something that's called dry needling, where you're just putting the needle in, moving it around, and creating an inflammatory reaction, because a lot of sort of the purpose of doing a trigger point injection really is to create inflammation, which sounds kind of counterintuitive when someone has pain. But as the body detects an injury and there's inflammation, there's fluids and enzymes and things that come to try to heal the process. So that's kind of the reason why people do these injections. Dry needling is a little painful and uncomfortable. So what I do is I combine lidocaine and marcaine, and I do the injection with lidocaine and marcaine, and I do move the needle around a little bit to get kind of that dry needling technique.
Right.
And lidocaine and marcaine are only supposed to have a few hours of benefit, but with the trigger point injections, they really can last for quite some time. Then some people do it with a steroid. I don't do it with a steroid for several reasons. One, because if you're trying to create an inflammatory reaction, that doesn't work.
It's counterproductive, right?
Exactly. Yeah. And then secondly, I think that you can't do them as often, and there's more side effects in terms of muscle atrophy that will occur with the steroids. And I'd rather be able to do it with the lidocaine and marcaine more frequently. And I honestly, even when I've done it a few times because patients really have requested to do it with the steroid, I haven't really seen any benefit from using a steroid.
Right, and then like you said, the repetitive treatments, you don't want to use the steroid because it can degrade the tissue and degrade the muscle. So
correct.
So that's the more important issue, is
absolutely.
Preserving the muscle and
the integrity of it. Absolutely.
A lot of upper trap trigger points are very common, and sometimes people don't understand a lot of headaches. You know, I'd say better than 50% are typically musculoskeletal in nature.
Right.
So if you correct posture, you correct trigger point issues, you correct, other
body mechanics, things that they do, right?
A lot of headaches go away. I mean, obviously
That's
there's a lot
true.
of other causes for headaches, but truthfully, they're not always, oh, I have a brain tumor, thankfully not, or some other issue. So
yeah, I definitely do trigger point injections for headaches. When I do trigger point injections and they're really coming in every 2 or 3 weeks for the injections because it's only giving them 2 or 3 weeks of relief, then sometimes I'll refer them to a neurologist for Botox because that'll have a 3-month relief, hopefully. But usually I do trigger point injections. I'll tell a patient to come in, have a trigger point injection, make an appointment to see me 2 or 3 weeks later to repeat it. After 2 or 3 times of doing that, then we sort of gauge how a patient is responding and should we continue, should we not continue. And I often like a patient to have physical therapy or chiropractic care within 24 to 48 hours of the trigger point injection because I think it really does work well together.
Helps to mobilize the joints around the muscles that are supporting the whole area. So.
Right.
That's terrific. Now, you seem like you're probably a quarterback for musculoskeletal care, is what really a physiatrist is, and you have the sports medicine background as well. A lot of people can see a physiatrist or a sports medicine physician with probably most musculoskeletal complaints to at least have an initial evaluation, a workup, find out, what's really going on. Is it something, like you said, does it need to go to an ortho? Does it need to go to a neuro? Does it need to go to another specialist? Is it something that, maybe you don't handle? But it is nice that people can go there not thinking that, oh, I have to have surgery all the time, or I'm going to a surgeon, I'm going to need surgery.
Right, and you'd actually be surprised.
Yeah.
Some people come specifically to a physiatrist because they don't want to go to the orthopedist because they feel, if I go to the orthopedist, they're going to tell me I need surgery. I want someone who's a little bit impartial because they're not going to benefit from surgery.
Right.
So a lot of them do like to come kind of almost as a second opinion to the surgeon because they want a true and honest opinion.
Yeah.
So it's kind of funny that way.
So, for labral tears in the shoulder and sometimes even the hip, it's kind of like one of those things where patients don't know exactly what the labrum is, and then is it always a surgical case or not always? It can be, it cannot be, and can it be rehabbed without doing surgery depending on what's going on there?
Right. So the labrum, especially for the shoulder more so than in the hip, it's basically a connective tissue covering that for the shoulder really works as a stabilizing factor. Less so for the hip, but they're kind of similar. And when it depends, when you have a labral tear, it depends what it's associated with. Is there a lot of arthritis in the joint? Is there also a biceps tendon tear? Is there a rotator cuff tear? And all of those things kind of help guide the treatment plan. Normally for a hip labral tear, I try conservative treatment first, whether it's a steroid injection and then physical therapy or just physical therapy, because oftentimes that's all you need for a hip labral tear. I've been actually recently to a sports medicine conference where there was a big argument between different orthopedists who were there, because some people felt, look, if there's a labral tear, you have to operate, because where there's a defect, you now have more bone rubbing on bone, you need to operate to prevent that. Then the other group was saying, well, you really don't, because when you introduce the arthroscopic utensils, then you're creating more inflammation, more irritation, and more arthritis. So I feel that it's always better to try conservative care first, and if it fails, surgery is always an option for a labral tear. But it doesn't have to be the first option, and it shouldn't be the first option.
Right, and that's again the nice part about your specialty is, patients do have the ability to go see a sports medicine physiatry doctor, get some conservative care. You work with obviously other specialties, physical therapists, chiropractors, other types of holistic, people, and it's a nice option for the people. So.
And I think I'm also a lot of people think that if you're an MD, you're not open-minded to some of the more holistic things. So I often refer to chiropractors. I often refer to acupuncturists. And we do talk about some of the, I'm not as well versed in them, but certainly some of the more herbal kinds of anti-inflammatories, as long as there's no contraindication with other medications. So I think that it's good to know that there is an MD out there that is open-minded to some of these other approaches, as opposed to just a surgical approach.
What is your experience, or what is your true professional opinion on a lot of these glucosamine DMs or DSMs and glucosamine products and joint formulas and fish oils, and versus, okay, go take Advil or Tylenol or so.
So many patients now really don't want to take medications because they read the list of side effects and they're astounded by all the different things that can go on. And a lot of people also, because we're living longer, have other medical issues that can't take anti-inflammatories for whatever reason, whether it's cardiac or renal, whatever the issue might be. So the other supplements are good options. So fish oil is a great alternative, but it does promote bleeding, so patients need to understand that it could interact with some of their other medications. Glucosamine and chondroitin, I think, are kind of benign medications or supplements that really don't interact that much with other medications that they're on.